All right. Thank you very much, Dr. DeWalt. That was the third of three excellent presentations. I'm right on top of it, Cindy. If I get closer, I might swallow it, actually. So I want to just thank the speakers for that. It's now time for roundtable members to ask questions or provide comments. Rima is demonstrating the evidence-based behavior of raising your name card if you have a question or comment that you would like to make. And I will start with Rima. Thank you.
Okay, my mic is now on. Those were excellent reviews and presentations. And I too have had some small experience looking specifically at EPIC discharge instructions and really have found them woefully wanting on a number of different levels. And I'm curious, I know that we started off with a policy statement and a challenge about the likelihood of required regs regarding what to do and how to present information, and the difficulty of perhaps squashing innovation, making it too prescriptive. But I've noticed that each of you also talked about with a focus on the content of what is provided, perhaps the order, perhaps the language, and no one has yet focused on the process. So I'm wondering if it might be acceptable as a policy requirement to absolutely insist on a particular process for the development of these materials that involve rigorous, but I mean rigorous, pilot testing with members of the intended audience and evidence that change has been made based on that pilot testing. So if there is a process in play, might that not be more efficacious than simply identifying the content that needs to be identified and included?
Well, I think that, again, you're going to have some of the same potential trade-offs. So there are definitely, where you can, pilot testing can be very helpful, it can be very useful, but if you create a lot of expectations around the steps to do something, it also slows down the process of developing things that might work better, or you might crowd out organizations that have much fewer research resources to develop those things. So it's a trade-off, and I'm all for trying to increase the amount of pilot testing we do on those things, but I do think you still have that balancing act.
I think we can also make great strides through R&D. As investigators, we can identify through focus groups and cognitive interviews and other research methods, best practices, and for creating these after-visit summaries in a way that achieve the goals that we all want them to. And I think one of the outcomes of that would be greater patient satisfaction, frankly. And I think that's one of the things that healthcare systems are really care about, and oftentimes care more about that than some of the sort of fine clinical outcomes that we all care about here. And so I think that might be one way in which we advance the patient-centeredness of the after-visit summaries, is just by developing them better and then demonstrating real impact.
Yeah, Alex, I think that's a great point, and I think one of the things that's happened in part as a result of the meaningful use regulation is that there are a lot of people hungry for best practices information, and to the extent that we can find ways to get that out there, create learning collaboratives, create clearinghouses of best practices, I think that could be really valuable.
Dr. DeWalt, did you have a comment to add to this?
I think they answered it excellently. I agree with everything Josh and Alex said.
Great, thank you. Patrick, I believe you're next. And let me remind roundtable members, please state your name and affiliation.
Patrick McGarry, American Academy of Family Physicians, and thank you for the wonderful presentations, both presenters here, and Darren, sorry you can't join us. I'm a little concerned in the chronic care model that we're missing the concept of locus of control of the patient. We submit ourselves to the healthcare system and to our doctors' care and we kind of acquiesce as a patient, our ability to understand that we have the ability to affect our outcomes in our health. And I'm not really seeing that in this whole discussion. We talk about in terms of patient self-management. I know I'm involved at the Academy with patient education, and I always have to think not in terms of the clinician, but of the receiver, the patient. In fact, many times as has been wonderfully illustrated today, it's extremely confusing. You're yelling at us with all caps and all this kind of stuff. So it's a tough thing, and I think, you know, as a patient, I'm speaking more of a patient advocacy standpoint here. It's extremely difficult to turn over our trust to our healthcare providers, and then upon discharge, okay, it's all on you now. Good luck. So it's a complex interaction of services and individual ability to affect your health outcomes. So I was wondering your thoughts on that. Oops.
Well, one thought about that is I think that down the line, much of that locus of control can shift with the greater use of personal health records, web portals, patient web portals, and electronic communication. When you're handing over a hard copy of something, that's we can optimize it as much as possible and tailor it to what the patients really want to see, and that will help move us towards that locus of control line, and patients lapse more optimally. But I think ultimately the electronic interface is going to provide patients much more flexibility for getting the information that they feel that they want, when they want it, and have the opportunity to act and react to that information. I still think that we're pretty far from that, frankly. I mean, there are some places that make inroads, but especially with populations of lower incomes and lower educational levels, and we have a long way to go for that. But I think that's the direction that we can go in to achieve those aims that you refer to.
All right, thank you. Did you want to?
Just quickly, I mean, I do think some of the, stage 2, as we talked about with view, download, and transmit, it means that there are more opportunities to get that information, find ways to get it and to transmit it to other people that are part of you, the patient's locus of control, right? Because you then direct where that information goes. The other thing I think, though, it's just a huge issue is around payment models, and to the extent that there's still just a huge incentive for every clinician to bring every patient into the office in order to get paid, that's going to continue to create a lot of problems around that locus of control.
Great.
This is Darren. If I could just jump in. I think, Patrick, you're right to raise that. You raised the chronic care model, which I had in my slides, and I just wanted to comment that I think the spirit of the chronic care model is to enable a prepared, proactive patient and to put the patient in charge and create productive interactions. And that I think that when we give out materials like the ones I showed, we undermine that because we make it too complicated, and that diminishes a patient's efficacy. And so I believe that this is that the after visit summary and discharge instructions, when done right, is an opportunity to improve the patient's efficacy around their own self-management.
All right, thank you. Cindy, you're up.
Hi, this is Cindy Brock from the Agency for Healthcare Research and Quality. And such terrific presentations and so much thought. I want to broaden, I think, Josh's question a little bit, which was around the policy dilemma that he recently faced at ONC in terms of how prescriptive versus how much room for innovation do you leave. And broaden it to think a little bit about what are the levers generally, not just in regulation, for trying to get vendors of electronic health records to make after visit summaries and discharge instructions more health literate. And, for those of us who have heard Terry Davis speak on this. She presented at the Roundtable a number of years ago and presented her own discharge summary from after a heart event and hospitalization and surgery. And she becomes apoplectic about what they gave her, even though she works in a medical school. She's not a clinician and just very passionate. We've had very good documentation that what is generally distributed is fairly poor. But I think that as we progress during the day, we're going to see some examples of what good looks like. And we know that there are different ways of doing it. And the real question is, how do we move the needle? Josh, you just mentioned payment. Is there market pressure that we can, stir up? How do we get that to move? And then I also want to acknowledge Darren's terrific point about this not just being about an IT issue, that we really face a challenge in terms of thinking about how do we prioritize that information, what is really the most important. And he raised the chronic care model. I wanted to mention that with colleagues, Assistant Secretary Howard Koh, Linda Harris, and Michael Parchment, who's sort of the new Ed Wagner over at the McCall Institute, co-authored an article in Health Affairs last year called The Health Literate Care Model, which was trying to take the care model and make sure that we infused health literacy strategies into it so that we get those productive interactions that are on the positive side of Darren's mechanistic pathway as opposed to the negative one. And I think there we're really talking about thinking about clinicians' workflows, what that tailoring process that Josh mentioned was so terribly difficult, what that looks like, and we need to struggle with how to make that happen as well as the ITN.
Responses?
I think a good example is what happened with the impact of the readmissions penalties. And you saw the impact on how that motivated hospitals to really think through their discharge instructions in a much more, instead of saying, okay, you got to do discharge instructions this way, now you have literally thousands of hospitals thinking, how do we improve our discharge instructions because we got to reduce our readmissions? And I think that has created a lot of incentive and a lot of positive work. There's still a long way to go, but I do think that.
Any ideas on the ambulatory side?
Well, again, I think it's the payment models, and it's the same idea. We organizations that are now focusing on keeping people out of the hospital, keeping people out of the emergency room, are coming up with new ways to do that.
Well, maybe another driver for that could be, the next iteration of meaningful use criteria says that the after visit summary has to have demonstrated impact or has to meet some formatting or other characteristics that make it health literate. I mean, you look at the evolution of the NCQA, patient-centered medical home regulations, and they went from infrastructure to and are sort of gradually moving towards patient-centeredness, and so it's an evolution of regulations driving, trying to push healthcare delivery towards patient-centeredness, but they're doing it stepwise, and it seems like meaningful use is also structured basically that way, and so maybe another iteration, and this gets to your point, Rima, about using the policy levers to ensure that the process is built in place. And so maybe that would be a strategy to ensure that these tools are really doing what they're meant to do and not just a checkbox, as you described.
All right, thank you. Winston.
Good morning. My name is Winston Wong. I'm from Kaiser Permanente, also a family physician and a member of the Roundtable. And the last comment I thought was very appropriate, and I'll just ask you if you want to explore that a little bit more in terms of being a bit more explicit with regards to the opportunity to link health literacy within the context of not only meaningful use, but also the patient-centered medical home. Because I think really what was described, and I think Dr. DeWalt touched upon this, it's not just about the literature that we give, but the actual loop back that we provide and the support to patients that we give in their transitions back to home, and hopefully to keep them out of the hospital as well. What could we really do in terms of making this kind of a linchpin of the process thinking, and whether you have any recommendations around that? Secondly, more specifically, I wondered if any of you had any experience in thinking about the issues that you raise related to patients who are non-English speaking. And I wondered if perhaps either it's even worse in that situation, or perhaps alternatively, because the sensitivity would be so high relative to a non-English speaking patient, whether there would be additional sensitivity and effort to try to be able to make these instructions and directions clear to a non-English speaking patient.
Addressing the latter issue, obviously it's an enormous issue that we in our clinical practice, we're in East Harlem, and about a third of our patients only speak Spanish, and then we have a large proportion of patients that prefer to speak Spanish, even though they're bilingual, and we cannot provide these instructions to them in their preferred language. I think we need regulations to really push that along. I think healthcare systems do want greater patient satisfaction, but they've got lists of 10,000 other things that they need to do, and many things of which really threaten their bottom line, like the readmissions issue. So, I don't know where that stands in our list of priorities among the executives at our institution, but I don't think that it's very high. I think regulations are, critically important for that. And then for your earlier point about integrating health literacy sort of concepts and strategies into the patient-centered medical home. There's a lot in the 2011 Level 3 patient-centered medical home accreditation criteria that are in a way oriented towards health literacy without a lot of explicit mention of health literacy. So I think again it's a regulations issue to try to push that further into our formal thinking about how we deliver care, because there are people like us at institutions who are thinking about this, but it's kind of ad hoc at different institutions, and until you really codify it and mandate that people adopt these practices, I don't think we would see widespread adoption of these concepts.
All right. Anything else to add quickly? Okay. By my count, we have 6 people hoping to make a question in 15 minutes. So if you ask a 2-minute question, you can do the math. Mr. Logan, it is your turn.
Thank you, sir. All 3 speakers certainly had one theme that was common, that in terms of discharge information, if it is overly specific and perhaps too comprehensive, that becomes overly prescriptive, overwhelming, and essentially harmful. What I would love the three speakers to address is the other extreme. What's the harm of when information is less specific, is much more selective, and where you, with premeditation and deliberation, omit information? There is one obvious problem that I'll just get out that I'm sure all of you will say, that kind of highly selective information certainly could omit things that are key to medical outcomes and key to care. But other than that, okay, I'm curious what you think are the barriers at the other extreme.
Yeah, I mean, I think that the big problem is that, and this is based on my own experience in doing a lot of research, either shadowing patients or doing focus groups with them or structured interviews, that patients typically, it's not that they don't want in-depth information, it's that they want very specific information. And in a sense, it really is, what they want is the ability to double click and double click and double click once they find what they're interested in. The problem is it's very hard to create systems that will ensure that we can make that happen. Now, but not at all impossible. I think that in the future, I think that's the direction that we need to go. I think that, there is absolutely just as much problem, and this goes back to my own dissertation research about 13 years ago, that there really is a problem when people are getting information that's not comprehensive about their particular needs, and there's just a lot of information out there that's not.
Just one quick comment about this. As Darren pointed out, it's this is just one part of the care delivery, and so when it's more complex, we have to bring in other tools, and so this is just to help, and I think it can be tremendously helpful. But some cases people need navigators or they need care coaches and other things. So I think your point is incredibly well taken, and finding out what the right balance of components are is part of the puzzle that we need to figure out.
Great, thank you. Kim?
Thank you. Kim Parson from Humana's Consumer Experience Center of Excellence, and I want to thank you all for the excellent and very informative presentations. And so my question or thought is around the consumer, the patient, on the end user, if you will. And I heard a lot of discussion around focus groups and putting information in front of them and getting their reaction and whatnot. And I'm wondering about co-creation with the consumer. And I can't help but think what I saw that a consumer wasn't engaged and involved in that design, and I'm wondering if if we're doing any of that. Are we engaging the consumer on the front end to help them help us know the way they want the information and help to tailor it in the best way for their use in order to get the best outcomes? And I say that overlaid that thought on top of all the other considerations that my colleagues have mentioned, right? Because all of those are, it's notwithstanding those. We can't just ask the consumer to to design without all these other considerations. So.
Well, I have a grant under review, and if it gets funded, then we will do exactly that. But that's essentially what has to happen. And I don't know if there are other groups that are doing that, but that is absolutely what needs to happen.
Yeah, I couldn't agree more. I think some of it also has to do with, this gets a little bit back to Cindy's question, in terms of the kinds of things that we can do is really to encourage more team-based care, because there's really, a lot of that work of co-creation. First of all, the physician is probably not the best trained person to do that. And second of all, it is, just from a resources time, it can be very time consuming. But in a model where the physician is part of a team, the team includes a health educator, a health coach, other people who might be able to work and might be more attuned to the particular needs of that person, patient, consumer. I think that could be really helpful.
Yes, and not to put yet another onus on the physician, we might even, is it possible to even back that up to where we're creating with the EMR systems, working with the Epics and the people like that to help engage in that creation as well.
Good points. Dr. DeWalt, just wanted to check in, shout out if you want to add. We haven't heard from you for a moment or two.
Thank you, Andrew. I keep wanting to add, but you're moving so fast. And I don't have that much to add. One thing to this point that I wanted to bring up that we've seen here in our hospital is that it's not just the doctor who's coming up with the discharge instructions, but the nursing team and the pharmacy team and then some other allied health teams as well. And in our current system, those are all separate discharge instructions. And that's just muddying the water even further. We don't know, we don't have a way yet to consolidate all of that into here is what your healthcare team wants to work with you on. And really bringing the patient into that would be ideal per the last point. I'll stop.
Thank you. Bernie.
Thank you, Bernie Rossoff. As we teach the team of healthcare providers, and it is a team function, as Darren just emphasized, regarding AVS and discharge summaries around health literacy, what are the drivers we should emphasize, other than perhaps what was already mentioned as policy requirements and expectations? I like to think of it around the national framework of the National Quality Strategy, the drivers being perhaps patient safety, family and patient-centered care, care coordination, even decreasing the leading causes of mortality, which obviously this will help. What are your thoughts about the drivers as I just articulated?
I think the National Quality Strategy is a great tool. I certainly I worked on it when I was at HHS. But I also feel like one of the really important things about the National Quality Strategy is it was able to create a certain amount of focus. And rather than, there are 20, 30, 40, dozens of things that we need to focus on, here are 6 priorities. And the 6 priorities, I think, you could argue about, well, maybe this, is more important than that, but I think it really creates a lot of important focus and guidance. So I would agree with that as a great framework.
All right, thank you. Margaret, I believe it's to you.
Yes, thank you. I'm Margaret Loveland. I'm a pulmonologist, but I'm at Merck. First of all, I want to thank you for those wonderful presentations. My thoughts were a couple that, first of all, no one has really mentioned the pre-discharge of the post-discharge summary and how the patients are educated about these. And I think that's a really important thing, because just to give a post-discharge summary to many people means really very little. I think the way that it's presented to them, explained to them, can make a huge difference. And I know from personal experience in our family that varies tremendously. I think some people go home and think that, with a complete understanding, and others no understanding, and they just go home thinking things are back to normal. So I'd like some thought given, to that. And several years ago, we had a presentation on how that was, education from an electronic point of view. Patients were taught their discharge instructions electronically, and that was really cool. Secondly, the point about post-discharge follow-up, I think, is so important. And just one comment that VRE is a subsidiary of Merck, and they've got this pilot going where they've got, for patients that are somewhat at risk, that every day they can log in and check whether they're taking their medications, whether they have questions, or whether they have specific symptoms related to their primary diagnosis. And the results seem to be pretty good, but granted, it's a pilot, it's pretty, it's small still. But it just shows how IT might be more important in the future. And the other comment sort of is putting together what other people have said is, you know, when we do consultations or when I send out responses, you always put the executive summary or the most important things first. I kind of wonder whether we shouldn't be thinking of something like that, putting the salient, the 3 points, like as Darren said, at the beginning. People can look at that, and then, you know, that's what they'll do the first 2 days when they're home. And then they'll read the rest and figure out what else they need to do. Because when they get home, it's like, I'm home, and that's all they want to do. So
Yeah, I think on both of those, that's a really important. I mean, I think the work that Eric Coleman has done on the care transitions model really shows the importance of that sort of leading up to the discharge, all the work that needs to happen. The one, not so much caveat, but important thing, of course, is you know, the research that was presented before around people, you know, often at the time of discharge and certainly before the time of discharge are just often cognitively impaired, and we need to be very mindful of that. So the ability to engage caregivers, family caregivers, is just so important at that time. And then, you know, the other piece around really what it is the dosing of the information, you know, is really important. You know, we have to remember that, you know, when we're prescribing information, it's the same thing as prescribing medicines, and we got to make sure that we get the right dose, the right frequency, the right duration. All of those things are very similar to medication prescribing.
Andrew, can I jump in there?
Of course.
So amen to everything that Margaret said. I completely agree with that and agree with Josh's response. I think that all of that other stuff has to happen, that the discharge instructions in and of themselves are not going to solve the problem. I do believe that the current state of discharge instructions reflects a generally disorganized plan put in place for the patient. And if the discharge instructions that we're giving reflect how we're teaching the patient now, that we're probably not doing it optimally. And so I think that by working on how we organize and present the discharge instructions will help the team as they prepare the patient in the pre-discharge and post-discharge arena.
Darren, you're not here, so you can't see all the nodding heads, but I'll just let you know that you had many in response to that. We had 3, but now we're at 4 more questions, so let's stop there, and we'll go with Bernard next.
Okay. Well, okay, I will. I will make a comment because that will take time. Bernard Dreyer, I'm a pediatrician. I think that's I guess this has been brought up before, but I guess I'm asking a process question or a strategy question. If we think that there's information overload, if we think that there's too much information on the discharge instructions after visit summary, and the patient or family will not be able to focus on what actually is actionable that they need to focus on. How do we get there from here? Because you know, I'm just thinking about all the handouts I get every time I get a prescription from the pharmacist. And we've been talking about how there's too much information, nobody reads it, nobody uses it, but we haven't gotten anywhere with that. And my concern about the discharge instructions is that it will become the next sheet, just and used in the same way that I use those pharmacy instructions, which is to throw them out, usually unlooked at.
Any response, or do we all just say, yes, that's a problem?
I mean, I guess, how do we prevent that from happening, or because I haven't heard yet, I mean, how we can decide that the detailed information that patients need and the actionable information is going to be there in some form, rather than we're going to feel required to give them everything or some part of everything, and it will not be understood by anybody.
Can you come to a mic? And then that'll be great. Thank you very much. We have a volunteer respondent. And identify yourself.
Hi, this is Mark Williams from the University of Kentucky, and I would say that we're already doing that. We're handing them big sheets of paper and I'll touch on this in a moment, about 20, 25 minutes.
Indeed. Well, now you're minus 30 seconds. Just kidding. Wilma, it's your turn.
Okay, I'll be quick. This is just piggybacking on what Winston Wong had asked, and then Alex's response, and then a kind of a compilation of comments that have been made so far. One, I just want to thank you all for these excellent presentations and bringing up. This is such a complex issue, and Darren, thank you so much for your paint a picture of the situation, because as I was looking at both of these examples, that was my thought. Geez Louise, what if they didn't speak English? You know, what if this person wasn't an actuary, and what if this person didn't have a wife? And so these are all the things that come up. And then talking about, you know, some of the patients' preference to speak another language, even though they might be perceived to be bilingual. When I work with providers and other healthcare folks, I remind them, you know, for folks who might have more than one language, or they are deaf and communicate via ASL, in what language do you get sick? And in what language do you process your emotions? And so these are some of the things that I just thought are adding to the complexity, but also making this a very rich discussion for our work today. Thank you.
Lovely. Thanks. So two more. One, I'll read out loud. It's from the IOM Roundtable member Kavita Patel. It's a specific question to you, Josh. Kavita asks what you think around registries and the concepts discussed being incorporated into registries in some way. Or better yet, she writes, how can literacy principles be better captured in some of the patient-centered registries? Maybe this wasn't brought up, so please go ahead and respond to Kavita.
So I definitely think that, and I was trying to get at this in an earlier question. I think there are ways to get to a greater level of specificity, and I think registries could be one mechanism for getting there. One of the things that's changing in stage 2 is the use of the HL7 info button, which is basically a standard that is, takes codes from the EHR and connects it with content. Well, we could be doing that with other things as well, and to the extent that we collect that in registries, that could be a great vehicle for getting there.
Great, thank you. And Lori.
Thanks, and I'll be quick. Lori Francis from Oregon Primary Care Association, and I work with federally qualified health centers. So I come to these and I always get so excited and so frustrated simultaneously that we have so far to go, and I'm sure that sentiment is shared in this room. I'm a nurse professionally, and I notice I recently had time with the old Ed Wagner, and not the new one, but the old one, and listen to his tale of woe in the health system and how fear subjugated his power. And I'm thinking about then in Oregon, where we're focused on payment cost, and quality, thinking about our high needs patients that end up being rehospitalized, who are primarily medically ill, but also have co-occurring substance abuse and mental health issues. And that's that top 25%. And then I come to these and we talk primarily about physicians being better at communication. And I'm wondering how we get to really focusing on patient priorities and truly using the team. So we always say, oh yeah, and the team. Patients need 18 hours a day to do their work. Oh yeah, they have a team. And I don't know how to move research to the use of community health workers. Discharge planning seems to be the least teachable moment in history. And how do we really change our system to have a different conversation rather than researching how well physicians can communicate?
Payment models. Improve payment that enables us to engage community health workers. I think there are a lot of programs that are going on now that are facilitating the use of alternative and adjunct members of health care teams like community health workers. In New York State, we have and in other states, there's the Medicaid medical homes, and that's helping to funnel funds into community health workers. Accountable care organizations, Sinai has an ACO, and we are diverting some funding to CHWs. There's lots of demonstrations and research studies going on that are engaging community health workers and similar, like lay navigators and others. But you're exactly right. I mean, that's where really meaningful and lasting education can happen. And all this stuff needs reinforcement too. It's not just to tell them at the point of discharge or even a week after discharge that you need to be taking your medications this way, but it's to check in and make sure that they're still taking them that way and correct them because they're not. So you're exactly right, and it won't happen on a wide scale unless we keep evolving the payment models. Also, the private payers are in many cases are kind of coming to the table where they're seeing that supporting these models of care delivery, helping to keep patients out of the ED and out of the hospital, and it's helping them to save money, so they're partnering and as well. So
great, thank you. Darren, if you're still with us, I know we're right at the end. I just want to take 30 seconds and not leave a misimpression. Could you tell us what you actually did for your first patient? Because you left it with an open-ended question, which some people might have thought that was the end of your care, and I'm sure it wasn't.
It certainly wasn't the end of my care. I'm trying to remember where I left it with the open question. The patient went home, and within a couple of days, the home health nurse came out and said, I'll come once a week, which was the wrong answer. And I was checking in with the patient because I knew how sick he was, talked to his wife, and she told me this experience. So I actually called the home health agency and talked to the nurse on call that evening. And she saw him the next day and now sees him 3 times a week. And he's still recovering. It's had a rocky road, but it was interesting to me how the home health agency kind of botched it until I stepped in. And then I've been able to have frequent communication with this nurse, and we've been able to keep this patient out of the hospital, not out of the emergency room, mind you, over the past 6 weeks since he's been out. But it's really required a lot of hand-holding and teaching of both the wife and the patient.
All right, lovely. Thanks for filling us in on that. I think it's time for break now. Let's just make a 10-minute break and come back. We'll be on schedule then. Thank you. And thank the speakers.